Meffert. I currently work for the Department of Dermatology, Division of Medicine for UTHSC. Prior to that, I was in private practice with Texas Med Clinic for a while, and for 28 years before that, I was in the Air Force. I actually started out in family practice and did that for 10 years before I got into dermatology. So I've sort of seen the whole skin thing from a number of different perspectives. Knowing that we have a mixed audience of different people with different backgrounds, some of this talk is geared towards how you might help one of your patients or clients, and other parts of the talk are geared more towards how you can take care of your own skin, because everybody's interested in that. I am, in fact, 97 years old, and minus 4 decades off of that. So basically, no financial haircuts, and yes, I probably do need a haircut. I meant to get that scheduled for this weekend. So the first thing to talk about is terminology. We're talking about different things on the skin. If you go back not too far in the literature, and especially if it has a English bent to it, you'll find the word senile used a lot. You'll find the term senile purpura, senile keratoses. We don't like the S word, and I also don't like liver spots, since it doesn't have anything to do with liver other than sometimes they're the shape of the liver. And the W word, wrinkles, people don't like to hear they have wrinkles either, so you use the term feature lines when we're planning surgeries on people. So you have feature lines, you don't have wrinkles. And most of what is considered senile or old skin actually is not directly or completely the result of having older skin, but living long enough to get too much sun. And so, in fact, senile purpura is actually solar purpura. Senile keratoses are seborrheic keratosis, but some of those will start out as solar lentigos on the arms and the hands. And then there's a senile comedos, which are these blackheads that some people get around the eyes. It has its own name, which is Fabry-Rockefeller disease, but also solar comedos would be the proper term, because they do tend to occur in sun-damaged skin, especially in people who have had a ton of sun over the time. So the things going to cover here are just a bit about dry skin, a bit about funny spots and lumps and bumps that people tend to get in their skin as it gets older, and then we'll talk about skin cancer, because that is a big concern for everybody. And also talk a little bit about, is sunscreen bad for you, because there have been some very recent changes in sunscreen labeling, which is good. They're dropping some of the terms which have been very deceptive in the past, and we'll try and explain where some of the myths are reality and some of the realities are actually myths when it comes to sunscreen and sunscreen use. Now, it is true, as we get older, our skin does change in the oils. That's why, for instance, you hardly ever see something like tinea versicolor in a 10-year-old. You tend to see it as you get into puberty, because the oils on the skin have changed. There are more of them. And why you very seldom see tinea versicolor above the age 40 is because the oils in your skin have changed again. You have fewer of them, they've dried out, and they've changed both in volume and their composition. The other thing which will tend to make that worse are drying medications. And I'll give you a list of drying medications, and you might be surprised. We have some of our uber drying medications that are notorious for it, things like isotretinoin, aka Accutane, or acitretin, aka Seriatane. Now, these are systemic retinoid, basically retin-A pills that dry you out, make your lips dry and crack, and can be make your skin all cracked and sticky. However, there are a number of other medications which can dry you out, maybe not quite as bad, but especially since people are on usually more than one of these, can add up to a really dry, itchy person. Also, people tend to overwash. We do something called patch testing periodically to look for skin allergies, where I take these things to somebody's back on Monday and tell them they can't shower and they can't sweat until Wednesday. And people are just horrified. How could I possibly not take a shower every day? Well, you just have to, or we can't do the test. People will tend to overwash the skin, and they will often use very drying soaps. Anything that is an antibacterial soap, except for possibly Lever 2000, is very drying to the skin. And that's what people have been taught to believe that they need, so that's what they use. And then if you throw in a genetic condition like ichthyosis vulgaris, vulgaris in this case is not meaning rude, but common. It is common dry skin or common fish skin, And it's an autosomal dominant condition, and it affects anywhere up to 25% of the population, with about 10% of them having it really bad because they got a gene from both their mom and their dad. And so there's a lot of things that will tend to add up to give you some problems. Now, the whole issue with feature lines, to not use the W word, people say, well, what can I do about my wrinkles? And they go, well, the best thing would be to invent that time machine, go back 40 years with a 55-gallon drum of sunscreen and convince your young self to use that. Now, when it comes to anything related to sun damage on the skin, whether you're talking about feature lines, whether you're talking about actinic keratoses, or skin cancer itself, there was this thing that was put out that you get most of your sunlight before the age of 21, and people get the idea that it doesn't matter now. All the horses are out of the barn. Some of the horses are out of the barn. And by developing good solar hygiene today, you aren't going to stop everything cold in its tracks. But all my patients who go from being sun-worshipping, fishing, golfing, hate sunscreen kind of people, if they actually do develop better habits, in 2 to 3 years, it may have a dramatic drop-off in their pre-cancers and in their skin cancers themselves. Especially if they start to use proper hats and protective clothing, or just don't go outside when the sun is at peak. Sometimes people say, well, I have to walk the dogs, I have to go outside, that's what I do. Well, you can always take advantage, and there's a slide later on in this, and talking about solar SPF. Is that if you go outside at a time when your shadow is longer than you are, you have my permission to not wear sunscreen. Now, if you think about this, what time of day is that? Well, it depends. The nice thing about saying if your shadow is longer than you are, you don't have to worry about daylight savings times, time zones, or anything like that. You're basically defining a time earlier in the morning and later in the afternoon when the sun is having to come obliquely in through the atmosphere, and the atmosphere itself will provide you a lot of sun protection. Smoking's bad for everything, and it's actually bad for your skin. It gives you wrinkles, and not just wrinkles, the pucker wrinkles from sucking on a cigarette. It actually causes wrinkles all over. It also causes acne, and increases your risk of squamous cell carcinoma of the skin. The mechanism of that, the latter, we're not quite sure. So here's someone that has ichthyosis vulgaris, or common fish skin. They've probably had dry skin problems their whole life. But when they're hit their 40s or 50s or even 60s, they started to develop this dry, cracked lake bed appearance, usually starting on the shins. Legs, because of circulation and other issues, and a little bit of chronic edema, will tend to dry out first and worstest. So there are some other things which will make that worse. If you have a bit of eczema on top of that, internal malignancies, and certainly malignancy treated with any kind of chemotherapy, HIV disease can certainly do that too, and medications. And these are the medications that I referenced before that will dry you out. They will make your skin itchy, flaky, scaly, and accentuate any feature lines that you have. And they include things like beta blockers, all the statins, of course, any chemotherapy, any retinoids, antihistamines can do it, cimetidine and ranitidine can do it. And then topiramate, Topamax is the trade name on it. It's an anti-epileptic that's now being used for all kinds of chronic pain problems. It can actually make you stop sweating completely. You say, well, that's great. I'd love to not sweat when I go out. I mean, not sweating at all, which in Texas can be lethal, especially to an older patient that happens to be put on it for, say, post-herpetic neuralgia or chronic migraines or something like that. So some of these medications can not only be an inconvenience, but because of their effect on the skin, can actually be quite dangerous. I mentioned overwashing before. One of the best marketed soaps in the world ever is Ivory. It was actually, if you know the history about it, it was a mistake. A guy, I think, was making soap, lye soap out west, and I think he had to hit the saloon or something like that, and left his batch, and it cooked wrong. And he ended up with this soap that floated. And everybody, he put it on sale, and everybody loved it. So then he had to actually make that intentionally. And ever since then, people have gotten the idea that Ivory soap is good for you. It is actually the harshest thing to use on your skin, except for maybe lava. It is the most drying soap out there. Now, I have some people that will just say, I'm sorry, I'm going to keep using Ivory soap. My mom used Ivory soap, my grandma used Ivory soap, my great-grandma used Ivory soap. We brought Ivory soap over on the Mayflower. You say, okay, may I make a suggestion that you get Ivory Moisture Care? It still has the Ivory soap logo on it. It's actually a Dove. It's a nice moisturizing soap. They will know that you've pulled a fast one on them because it will sink to the bottom of the tub. It will not float. But it's much, much better for their skin. So what I tell people is, okay, lose the Ivory soap, and also all the other deodorant antibacterial soaps, except for maybe Lever 2000, which is sort of an antibacterial Dove. But Irish Spring, Zest, Dial, very irritating to the skin, will tend to over-dry people. And then they're grinding their skin with scrubby things in the shower, and then they get their nice harsh towel and they're belt sanding themselves to dry themselves. And these are all bad things to do for your skin. So the best thing, if your skin is already dry, is already cracked, don't use a harsh soap, short showers, pat dry, and then immediately use whatever moisturizer or lubrication you're going to use. Yes, ma'am?
What's your take on shower gels?
Shower gels are somewhat drying because of the alcohol content in it, but I actually find that people don't wash and scrub quite as long with them, so it ends up being better. It's actually a little bit of a diversion, but a good one is to talk about hand sanitizers for chronic hand dermatitis. If you have a chronic hand dermatitis due to washing your hands, which just by the number of people here, several of you do, it is actually easier on your hands to use a hand sanitizer when it is appropriate to use a hand sanitizer than to always be using soap products. The reason for that, I mean, there are times that you need to do a regular scrub if you actually have particulate matter on your hands that you need to scrub off. But just for that interval between patients sort of thing where you properly should do something with your hands, the alcohol of a hand sanitizer will briefly solubilize the oils on your hands, and then as it evaporates, they're left there. Whereas, of course, if you go in there with a soap and a surgical scrub, you degrease your hands and wash that last, all that oil that you've taken the last half hour to try and build up in your hands, you've washed that down the drain. And that's much more irritating on the hands. So whenever it is okay to use a hand sanitizer, use a hand sanitizer. Of course, the other thing I always try to get my hand dermatitis people to recognize is there are times that you should wash your hands and times you could wash your hands. Go ahead and do the shoulds. Don't do the coulds. And if you're above the age of 20 and you're still doing the happy birthday song 3 times or the ABCD song twice, you need to get over that and back off. You're only allowed 1 chorus of the ABCD song, not 2, and you're only allowed no more than 2 happy birthday songs, depending on how fast you sing it in your head, not the 3 or 4 that some people were taught in grade school. Oh, so in terms of what kind of thing to lube your skin up with, you don't have to go buy expensive Lancome stuff and things like that. Whatever's on sale, whatever you like the bottle of, the generic brand, the H-E-B, Walmart brand, or stick with one of the name brands that make good, relatively inexpensive products. Neutrogena, Aveeno, Basis, Cetaphil, CeraVe. They all make very nice products at a much better price. And if you don't have a coupon, you can always get a coupon online, usually, for any of these things. Actually, that's a helpful hint for any medication you ever buy that you have a copay on or an over-the-counter you're going to have to buy. Go online and see if you can find a coupon. There's almost always a coupon for everything. Ammonium lactate at the 12% comes both prescription as lacthydrin and non-prescription as amlactin. It's the same stuff. Over the counter there is a 5% because some people find that 12% a little bit too irritating. Now that will actually help get some of that dry flake off. And it does have a moisturizing effect, but it is also a little bit more irritating than just your everyday moisturizers. As far as using either prescription retinoids or over-the-counter retinals and retinols, these actually can work for wrinkles. They're pricey and more expensive than just a regular facial lotion, but actually can help feature lines and dyspigmentation. They work slow, but you have time, and I say they do work, and work a lot better than some of the very expensive things that people are, shelling out, $200 for a little tin of mouse placenta or something like that. That, there's a lot of stuff being sold out there that does nothing. It is absolutely worthless. And I feel bad when a patient will pull out a shopping cart and they'll line up what I know is $500 or $600 worth of very expensive skincare products, most of which are no better than a $15 tub of Aquaphor. Actually, some of them are $15 tubs of Aquaphor, which they pay $200 for. Actinic keratoses, of course, is a result from the sun. And as I say, not all the horses are out of the barn. It is never too late. Someone says, "Well, I'm old. It doesn't make any difference now." And they go, "Oh, are you dying next year?" Because they say, well, basically, you don't want to be 10 years further down the line and wish that you figured something out 10 years ago, because it's never too late to do something. This one may be a little bit too late. It can get better if you stay out of the sun, but this is one of these, the damage is done, but you can make it worse sort of problems. And that's poikiloderma of Savant. And pretty much anybody that's lived in Texas any period of time that has seen some sun has this to some extent. Men usually have it on the sides of the neck if they are foolish enough to have short hair. Women will often have it going down the V of the chest if they often went with nice V-cut clothing. It hits thin skin, the thin skin of the neck and the thin skin of the upper chest and anterior neck. And poikiloderma means varying skin. And so what you see brown, you see white, you see red. Now sometimes lasers can take the red out. Bleaching creams won't do anything for the discoloration. But aggressive use of sunscreen, even if you're going out to check the mail or drive the car, will help keep this from getting worse. And over time, your body can repair some of that. A lot of times, people say, "Well, I don't think it's the sun." You can find out whether they're the driver or the passenger of a car. If they're usually one or the other. If they're usually the driver, you will often find the right side of their face, their right arm, their right neck. I said that in reverse. Their left side of their neck, their left face, and their left arm are worse. If they're usually the passenger, it's usually the right side is worse. There'll be some symmetry. And the reason for that, it of course is true of our older patients that were doing a lot of driving in the pre-air conditioning era, but a lot of the most damaging aging sun rays are ultraviolet A, and that goes right through window glass. And so if you're just, if you're spending an hour in your car every day, either commuting or driving kids around, you are getting an hour's worth of sun, ultraviolet A, right through the glass. It's not going to give you a sunburn. It will tan you over time. So what are the different types of funny spots that people get? Solar lentigos are these dark spots that people get on the back of their hands. Eventually, some of them can eventuate to become seborrheic keratoses. I don't know where the term liver spots came from, but it doesn't have anything to do with the liver. Of course, the question is always, if someone is making a new, funny-looking spot, is it cancer, is it melanoma? Generally, you do not make a lot of pigmented moles above age 35. Now, it doesn't mean that a mole you make when you're 40 is guaranteed to be cancer, or a mole you make when you're 20 is guaranteed not to be. But as a rule of thumb, you should not be making new pigmented moles above age 35. However, you are making lots of these. That's when you make these. Now, other things you can do for those, retinoids, even just a generic retin-A or those retinol and retinol products, they can fade it a little bit. It takes time. Glycolic acid works a little bit faster. Cryotherapy, basically liquid nitrogen, works even faster still. I don't recommend trying to use the Dr. Scholl's wart stuff on it. You get this big giant Q-tip thing on that, and you're going to end up freezing the whole back of your hand. And if you have any color in it, you may end up bleaching out the normal skin while you're trying to lighten the spots. Of course, sunscreen to keep things from getting worse and to give your skin a chance to recover. I say the bleaching creams, so whether you're talking about the over-the-counter 2% hydroquinones or prescription products, generally don't work as well for these. And so, people can get the spots in any part of the body that's been exposed to the sun. This is sort of a prototype solar lentigo that may eventually become a seborrheic keratosis. They often are irregular in shape. They often are larger than the pencil eraser, which is the D in the ABCDs of melanoma. And they will often have varying color. If there's a question, let one of us get a look at it. We'll figure it out. This is just a solar lentigo. That's a melanoma. And this is a really big lentigo. These things sometimes can be huge. I've seen them several centimeters across. I've seen some melanomas a few centimeters across, but the biggest pigmented lesions I've seen are more likely to be giant seborrheic keratoses or solar lentigos than melanoma. Now, another thing that will happen, some people advertise they want to assess you for sun damage and they'll take ultraviolet light pictures of you. We actually use this to figure out whether someone has vitiligo that we're not seeing, or if they have melasma, that discoloration of the cheeks, is it superficial or deep. And that's because surface pigment, when you put it under black light, really stands out. And so, you know, this person here, in regular light, probably just looked like they had some very light brown spots here and there. But put them in the black light, really brings them out. So that's why you don't go to the disco when you're old. This is something I was pointing out. What happens sometimes, though, someone's been trying to freeze this, and so you end up with these pale areas where they've killed melanocytes, and now this thing looks really weird. And so it's always best, if you are going to embark on a treatment, give a really good description of what it looks like before you treat it, or people may start to wonder what was there. Now, actinic keratoses, very common, these little crusty things that people get. A lot of times I'll ask a patient, have you ever had skin cancer? And they'll say, yes, I've had hundreds of them. The doctors are freezing off my skin cancers. Well, what they said was pre-cancer. Hopefully they're not actually charging the Medicare and the government to destroy cancers that are actually not invasive cancers. There is this question right now, and some pathologists want to say that these are all carcinoma in situ, that is superficial squamous cell carcinoma. That's mostly, I think, so that they can bill more for it, because you can do the same thing to a spot, whether you're removing it or doing a histologic evaluation, and you get paid much more if you call it a cancer than if it's not. And so there may be some ulterior motives in that. Practically speaking, most of these sun damaged spots here will never become cancer. But the problem is we don't know which ones will and which ones won't. It's something like 1 in 100 maybe will become an invasive squamous cell carcinoma if you don't do anything about it. So the person that has 3 or 4 actinic keratoses on their temples and on their ears, we'll go ahead and treat that, but I'm not that worried about this person. You look at this hand here, and you're probably looking at about 20 actinic keratoses right there. I guarantee their other hand looks like that, their arms look like that, maybe their legs look like that. So these are the people that need closer surveillance, watching out for skin cancer, and need the ones they have treated. We have lots of ways of treating these. If you just have a few of them or a few thicker ones, we'll do the liquid nitrogen. 5-fluorouracil comes in many forms. That's the one that people put on for a couple weeks and it tears up their skin, but can really help freshen up skin nicely. I'm not a big fan of diclofenac. It's supposed to be the kindler, gentler 5-FU. You use it for months and it's supposed to not irritate the skin. I found it either didn't work or generated an allergic contact dermatitis. Then I got talked into trying it on a patient who had actinic cheilitis, basically actinic keratosis of the lip. Older lady, she started to hallucinate. I thought, well, I'd better report that one to the FDA. It turns out that actually, no, that's a established 1 to 5% complication rate of this medicine is hallucinations. Don't tell the teenagers that at all want it. So, go use your solar rays during your rave. So, I just got back from Las Vegas where they had the Electric Daisy Carnival. Las Vegas is a weird place anyways, but put something like the Electric Daisy Carnival there with 150,000 20-year-olds in costume, and it makes weirder. Anyways, I digress. Imiquimod, aka Aldera, though there's another form of it of a lower percentage called Zyclara. These are effective for actinic keratoses, and they do take some time, and they do tear up the skin some, and they're expensive. This 5-fluorouracil is still surprisingly expensive for something that's been around for over 20 years. And what has been happening is that people that make all these different 5-FU products are always changing their prices so they're just behind whatever imiquimod costs. Not that there's price fixing going on or anything. A new product here is this ingenol rebutate, known as Picato. This is kind of a sneaky one. It's very expensive, so I've hardly ever written for it. Your treatment on the face is 3 days of a lower strength, and your treatment on the arms is 2 days of a lower strength. and the patient won't see anything or feel anything while they're putting it on. And then about 10 days after you've done the treatment, they will blow out with redness and scale and itching, much as if they've been using 5-FU. So kind of a sneaky way to make sure a patient uses it. Whereas unfortunately, some of my patients will start in on 5-fluorouracil or imiquimod, they'll start to get irritated and they'll lose interest in treating. So they're kind of already committed on this one. I really like photodynamic therapy. I used to like chemical peels more, and these aren't the glycolic peels for melasma. These are aggressive trichloroacetic acid peels that actually do strip the top layer of the skin. Photodynamic therapy, we paint your skin with a light sensitizing chemical and then stick you in a U-shaped blue lamp for 16 minutes and 41 seconds, which is 1,001 seconds if you're doing the math on that. I'm sure that was scientifically determined. And it can really help clean things up relatively gently. The downside of that is that it leaves you exquisitely light sensitive for 24 to 48 hours. And when I say light sensitive, I don't mean, go out to the pool without sunscreen. I mean, if you were just sitting in this room with these lights, you would start to feel burning on your skin. It's a visible light problem. But it's really nice. It's fairly fast and cleans things up nice. Now, there's various other things that people tend to pick up. We already mentioned the seborrheic keratoses, these brown stuck-on things people get on their back. Skin tags and cysts are my two most common procedures. I do more of those than I do all the skin cancers combined. Sebaceous hyperplasia, I'll show you some pictures of that. Cherry angiomas, aka red moles, and anybody can still get warts. And then there's lipomas and just regular old moles. So the British call seborrheic keratoses seborrheic warts. We don't like the term because to us warts are HPV related, and some people will make a few, some people will make a lot. Some people make 1 or 2 on the scalp. Some people make hundreds across their back. There's certainly some strong genetic issues in here, and some may have something to do with it when it involves particularly the face or the legs. Now, some people have associated having lots of seborrheic keratosis with something called the sign of lesser Trellat, which is supposed to mean internal malignancy. When I was in family practice, that's what I was taught. It's actually not true. What is true is that if you have, say, a younger person who had no seborrheic keratoses and suddenly explosively develops lots of irritated seborrheic keratoses, lots of red, pink, itchy ones, that's the person you need to worry about because they may have increased TGF-alpha, they may have increased human growth factor, but something is cranking those things up. But this guy here, that's taken 2 or 3 decades to accumulate that collection of barnacles, he does not have any increased risk of malignancy other than what his age would give him. If you actually do have this eruptive one, usually it's some form of adenocarcinoma. We look to the bowel, we look to the lungs on that. So this person I'm not worried about. This is actually a 47-year-old that ended up having lung cancer. Histologically, if you biopsy any of these red, very itchy bumps, they are seborrheic keratoses. Pure and simple, no cancer in those. But this was a sudden onset, very itchy, and he did have an internal malignancy. You will find some literature suggested if you have lots of skin tags, you have lots of colon polyps, that is not borne out either. You do not have any increased rate of colon cancer, colon polyps, or colon cancer other than what your family and age would give you as risk factors anyways. People hate these things. I don't like freezing them. I snip them off. I electrocute them. I snip off the big ones, electrocute the small ones without anesthetic. So that must hurt, and the answer is yes, but the motivated patient can put up with a lot. So that way I don't have to numb up, poke a needle under each one to do it. By the way, don't tie hairs to these and some of the other things. And this is probably a good time to mention a product that is, you see it on the internet, you see it on TV, it's supposed to be the stuff you're going to smear on, and they say they treat moles, warts, skin tags, and everything. It's actually a blood root compound which has been used for skin stuff for only, about 400 or 500 years. And it doesn't work. So, if you're thinking of getting it, don't get it. If your patients or clients ask about it, or your neighbors, tell them to save the money. Sebaceous hyperplasia sometimes can look a lot like a basal cell. You end up with this lump. It tends to occur on the central face, especially around the nose and eyes, and often has a little dell. What has happened here is that the oil glands around that particular hair follicle have gone macho. And they make this sort of white-yellow lobulated papule. Some of the retinoids, either taken systemically, like something like isotretinoin, or smeared on, like good strong retin-A, tretinoin generic, that can shrink them a little bit. If you really want them gone, you have to do destructive things to those too. And I really like my hypercator with electricity for those. And those, those do much better if you don't numb them up, because you don't want any extra fluid in there, because the oils in these lobules here, you need that to transmit the electricity. And the thing that wide surface things don't work with that, they actually start much deeper in the skin. Freezing doesn't work as well other than to just knock the top off with those. A lot of times people are concerned about their red moles. These are called cherry angiomas. They're little tangles of blood vessels. Everybody will make a few. They're usually on the trunk. Some people will make more and they'll appear on the face, arms, or other areas. No cancer risk at all. I know it sounds redundant, but I do electricity works with these too. There aren't any topical creams you can do with this. And so here you're talking about electricity, laser, actually cutting them out, or just giving them a name and leaving them be. Rosacea is very common in our patients that get older. When you talk about some of these red spots and some of these other barnacles, people that have rosacea are more likely to get that sebaceous hyperplasia around the central face, which can confuse things. This is not just a simple acne problem, even though it has the name acne rosacea. There are some medications that we will use with both of those. And when it's in the redness phase, some of the things like metronidazole, aka Metrogel, will work with that. If you're actually making pustules and deeper nodules, we like to go with an antibiotic, usually something in the tetracycline family. The concern is always that you might end up with rhinophyma, which is this disfiguration. It's actually a fibrous scarring. Don't really see a lot of redness here anymore, and that's because the rosacea is burnt out and left this. Most people with rosacea will never go on to this, and there's probably some genetic determination for this. The main reason I show this is that if you do have a patient or a family member with this, there actually is something that can be done for it. I don't do it, but there are there's a variety of ways of doing it, either to use a laser to vaporize the excessive tissue, to use a special electric scalpel to carve away the tissue, or even just use regular scalpel techniques and then be ready to deal with the bleeding, which is significant. Bottom line on all these is you're basically carving the nose. You're carving it down into something that looks more like a nose. Now this is red and shiny and looks scarred, so it's not normal skin, but I think anybody would agree it looks a lot better than that. And so there is something that can be done if you can find someone that, some dermatologists do it, some plastic surgeons do it, some ENT surgeons do this. But these people don't have to suffer this, so there are some things that can be done. Other things in terms of rosacea that a lot of patients have noticed is that spicy foods, hot liquids, and alcohol all tend to make it worse. Now it's hard to tell someone, okay, avoid all those things and your rosacea will go away, because you can't say that. But it may help get it under control with some of the other things that we'll do. Either topical, if it's mostly just red, or oral agents if it's a little bit more bumpy and all. Most moles, the pigmented moles, they start out as flat, dark spots. They tend then to raise and become raised dark spots. Then they lose their color, and eventually they can go away. And so your goal is to outlive your moles. Now I say eventually go away. I mean, like 90 or 100, getting the Christmas, the birthday card from the president, that sort of thing. These are very common, but changes other than slow changes are things that we need to hear about. Most melanomas do not arise in pre-existing moles. They arise on their own. Now, what can be confused with an intradermal nevus, or a common mole at times, is a basal cell carcinoma. They can be bumps, they can be slightly smooth, slightly shiny, and they can become quite large, in fact so large that you wouldn't even recognize it initially as a basal cell carcinoma. Now, I see about one of these every maybe every 2 years. I'll have someone come in, it's usually a little old lady, coming in from a nursing facility with giant basal cell. And the problem is oftentimes dementia is an issue, and it's really tough conversations you need to have with the family sometimes. Because now we're not talking about little surgeries, we're talking about huge surgeries. And sometimes the better thing to do with basal cell is just to watch it, rather than do very aggressive, difficult to manage, difficult to take care of surgeries. But that's something you talk to the surgeon, you talk to the family, and of course involve the patient when it's appropriate to do so. This lady said that this has been going on for 3 months. No, it hasn't. It's been going on for 30 years. It takes a long time for that to happen. So a lot of times when people first go to see the physician is when the middle of them just completely outstrip their blood supply and necrosis, and then they end up with chronic bleeding from these. Now, a lot of things that people will think are psoriasis or eczema or ringworm or something like that, and be treated. Anytime you're treating something with a medicine that should be working and it's not, you need to consider not that you have some monster ringworm that is resistant to loperamide and topical Lamisil and everything like that, but maybe it's not ringworm at all. Superficial skin cancers, both squamous cell carcinoma and basal cell, can look like a lot of things. They can look like psoriasis, they can look like a tinea infection. Now, I said that one thing with the big giant patch on the scalp that someone said, this is all developed in 3 months. I'm not going to call my patient a liar, but I'm kind of thinking, file that away. I'll write it down, but I'll put it in quotes in my chart, because I really don't believe it. This is one I would believe. Keratoacanthoma are these little volcanoes of skin. They are in the squamous cell carcinoma family. In fact, the report will usually say squamous cell carcinoma, keratoacanthoma type. These things really can grow fast. This thing might have gotten this big in a month. And I know that because I have had patients that I've seen, and then I see them back in a month, and it's there. And I'm sure it wasn't there before. I would have noticed that. On the other hand, I've also done biopsies on these things and had them go away. One of the other names for this is self-healing squamous cell carcinoma, except usually they don't. The biggest one of these I've ever done on the face was that big. Basically took over an entire cheek. The biggest one I've ever dealt with of a keratoacanthoma was on the arm that I'm not exactly sure how big it was, because it basically looked like a tortilla draped over their arm. It almost touched on the inside as it expanded. And that's something that big does take time, but these things can grow very rapidly. A lot of times people think they're warts or pimples when they first start out, and the nice thing about these, as awful as this looks, and under the microscope, these look even worse. They just are really scary looking under the microscope. But their chance of metastasis are far less than other types of squamous cell carcinoma. A lot of people will get these cutaneous horns. I've sometimes seen world-class horns. The issue with the horns is what's at the base. It may be an actinic keratosis at the base. It may be a squamous cell carcinoma at the base. If you just kind of scrape off this keratinaceous horn and send that to the lab, the report you're going to get back is horn, and it won't tell you what you need to do about what was going on at the base. I think this one happened to be a squamous cell carcinoma, but you don't know that unless you take some of the skin underneath the horn. Now, a lot of times people have tried things. They tried over-the-counter wart treatments on things, and sometimes they bought that blood root stuff that I just told you about, and it can change how things look. This is a melanoma that actually had been frozen several times. Someone thought it was a seborrheic keratosis, and it looks like they got the middle of it, but of course it's getting bigger and bigger out this way, and there's some in-transit mets down here. If it's not reacting the way it should, it's best to send it on to someone who can take it on. This is a melanoma that was not frozen in the middle. I took a good history on it, and it just grew this way. And this also brings up the whole issue of, if I'm going to do a biopsy of a melanoma, how should I do that? The best biopsy of a melanoma is to take the whole thing and send the whole thing to the lab. You will still find in some literature that you can do little punch biopsies scattered around this in the most suspicious part. What I'm here to tell you is that the most diagnostic part of this melanoma may not be the darkest part, may not be this part here that the patient says is the new part, the brown part growing off to the side. This may be thin, this may be thicker, but the part that's going to give me my best guidance on what I need to do with this may be that white area in the middle. because that may have melanoma regressed on the surface, but very deep. And everything we do with melanoma depends on how deep it is. So just doing little punch biopsies around, whatever you think looks the worst is not the way to go. Basal cells, carcinoma and squamous cell carcinoma can have pigment. In fact, if you have pigment in your skin and you get a basal cell carcinoma, it will likely be pigment. On the other hand, melanomas may not have pigment. Not always. This is an amelanotic melanoma. It just looks kind of like a beat up mole, kind of maybe a basal cell. But this is actually a melanoma here on the alar edge. And this is the other reason why, if you actually are taking moles off, the patient doesn't want to pay extra to send it to the lab, never throw a mole in the trash can. Always send it to the lab to make sure that it's not something surprising. Now, melanomas, we are seeing more of them, we are catching them earlier, and it is felt to be due to excessive sun in our population, recreational and otherwise, recreational and cosmetic. But melanoma can appear in areas that see little or no sun. So this is a melanoma in between the toes. And that's also why when we're doing a skin exam, really if we have a high-risk person, we're going to flip their hair, we're going to look between their toes, we're going to do a genital exam and look all over. Here's another amelanotic melanoma. It's frozen as a wart several times. So again, if it's not getting better, someone needs to get a piece of it. Not all melanomas have color in them. The last malignancy I wanted to mention is one that is much more common in older patients. Cutaneous T-cell lymphoma, also known as mycosis fungoides. It can look like anything. It can look like eczema. It can look like psoriasis. It can look like a contact dermatitis. Most patients who have CTCL do not have a life-threatening disease. Most of these will never go on to the nodular CTCL or to the hematologic CTCL that can kill you. Most people are just bothered by these itchy plaques, which actually will get better with steroids. Especially potent topical steroids will make these feel better and make them seem to go away. You say, is that bad? Not necessarily. If all someone has is a patch like this in one place, super potent topical steroids may actually be the treatment of choice, because for most of these patients, this is not a life-threatening disease. It often takes more than one biopsy, though, to make the diagnosis, and sometimes we suspect it, we'll biopsy it, they're not getting better, we'll biopsy it again, and sometimes it's one of the third, the fourth, or the 12th biopsy that does it. So how do you prevent all this? I've heard that sunscreens cause cancer. What about this? So what's the best sunscreen? Live in a cave. Move to a higher latitude, not altitude. Higher latitude, you move up north a little bit, you'll do a little bit better. I already mentioned this, don't go out when your shadow is shorter than you are. Sun protective clothing, there's a variety of brands. They're a bit pricey, but they wear well, and they're actually made for covering yourself up in hot climates. A lot of them were originally developed in Australia, which actually is a great experiment in nature where you take exactly the wrong skin type and put it in exactly the wrong place. But it takes all these things. Australia has now actually seen a decrease in melanoma since they have over a decade behind them in the Slip, Slop, Slap campaign, which is slip on a shirt, slap on a hat, and slop on some sunscreen. And their melanoma rates are actually going down. And so we could certainly learn from that. One of the things that my academy is always trying to do is to try and put at least some restrictions on use of tanning booths, especially in kids, before they get addicted to them. And incidentally, tanning booths are addictive. People have actually measured endorphins and things like that. It is, I wouldn't say it's as addictive as smoking, but it is hard to stop once you start. So the best sunscreen. Well, nowadays, there's really no point in using a UVB-only sunscreen. In fact, the original things about, that came out a few years ago, that sunscreen causes cancer. Well, two issues with that. One is, this was all historical data, people trying to remember their sunscreen use now 20, 30, 40 years down the line. Two, the sunscreens they were using back then had an SPF of 3, 6, 10. Back 30 years ago, an SPF of 17 was a pretty strong sunscreen. We have SPF of 30 usually in most of our facial moisturizers now. And the other is they were all UVB only. And so UVB is the burning rate. Now it is associated with basal cell carcinoma and squamous cell carcinoma also. But as far as melanoma is concerned, which some people are linking more with UVA, if you use that UVB blocker, that lets you stay out in the sun longer, and if it's not blocking UVA, you're getting extra UVA. Now, pretty much all sunscreens are going to be blocking UVA and B, and they'll say so on the bottom. We don't have good measurements of equivalent SPF for UVA. But when people say, what's the best one? Whatever you'll use. It used to be that the sprays, which guys prefer for either hairy arms and hairy chests and not so hairy scalps, had low SPF and didn't last long. Actually, the newer ones we have, several manufacturers make good spray-on sunscreens now with high SPF, some of which you can even spray on wet skin, which is really nice. So, you know, whatever the patient was used is what they should. Physical blockers are effective. They are the ones that make you pasty white. So, I know you want me to talk about lotion. So why do we have SPF of 60 or 80? What SPF means, an SPF of 10 means if there's a certain amount of time I can be outside till I burn. If I put on that sunscreen at 1 gram per centimeter squared, which is pasty white, I can stay out 10 times longer. You say, well, why would you ever need anything longer than that? If it takes me 30 minutes to burn, and now I'm going to say it's going to take me 6 hours to burn or 5 hours to burn. Well, the problem is people tend to smear out their sunscreens to one-third to one-half of the SPF. The sun actually degrades the sunscreen, and of course you can sweat and wash it off. And so that's why you start big. Go ahead, start out with your 60, smear it out to 30 or 40, or even 20, and then reapply in a few hours as you're starting to sweat it off, and that's how you stay out of trouble. But say, some of the new gels and sprays are pretty good. Sunscreens can cause problems, they can cause acne. A lot of them are not made for the face. People that have problems breaking out every time they use sunscreen, what I have them use are the facial moisturizers, and Aveeno, and Purpose, and CeraVe, and Neutrogena. All make some nice ones. SPFs of 30 up to around 60 in facial moisturizers, which are made for the face, and so they are made for acne-prone skin. They can also cause allergic dermatitis or photoallergic dermatitis. And then there's this question of vitamin D. Are we blocking your vitamin D so that you're either going to get cancer or get rickets or get something like that? Because everybody is vitamin D deficient. I'm sure you have a lecture on vitamin D. We are all vitamin D deficient. And it actually turns out that no, they actually do not block that much. I already kind of mentioned this about this whole sunscreens causing melanoma. The answer is no. And there are many factors on why that was the case. Sun protective clothing, there's several brands. I don't have a favorite. You know, Solyndra, Coolabar, Solartex, they've been around a long time. Frogwear has since gone under. But all you do is just put in sun protective clothing in your browser, and you can find several different brands and several different companies. This is not sun protective clothing. Does anybody, in fact, you say, well, yeah, I mean, they're exposed skin. No, the clothing itself, does anybody know what these swimming suits are? They are tan-through swimsuits. They are designed to cover up your naughty bits, but let the ultraviolet light through so that you tan without getting bad tan lines. Which means that the longer these products are out there, the more I'm going to find skin cancer literally where the sun shouldn't be shining. And that's the thing you have to keep in mind. If you have a young person that looks like, passing looks like a skin cancer, it's probably a skin cancer. If you have something in what should be a sun-covered area that looks like a skin cancer, it's probably a skin cancer. So what is the issue with vitamin D with my sort of the dermatologic perspective? You get it in your diet. Sunlight naturally induces a fair amount of it. But there are these issues of is it cancer preventive? Does it help your circulation? Is it good for your heart? Is it good for your brain? A lot of it has focused on the cancer issues, including skin cancer, but actual internal malignancies too. Rickets is really not so much an issue anymore. You can't use so much sunscreen that you're going to get rickets. Now, if you have a bizarre diet and you're inside all the time and never get any sun, potentially it's possible, but the RDA is so vanishingly small to help prevent rickets that it's really hard to get rickets. However, with no exposure to sunlight, and people have actually looked at a study here on how much extra vitamin D do you need to take to prevent adult rickets, and they looked at a population here which was interesting, Danish Muslim women. And that's sort of a double threat. They are mostly covered, and they are in a latitude that is so high that they aren't getting very much sun anyways. And it was found to maintain any kind of significant vitamin D levels, they really needed 1,000 units a day to keep that up. So people have tried to develop, well, is there an equivalent between the amount of vitamin D you can generate on the skin versus having to take a pill? And the answer is that 1 MED, that's a minimal erythema dose. So this is sort of the opposite of sun protection factor. This is not sunscreen to prevent turning red. This is enough sun to turn red. So you get enough sun just barely to turn red wearing your standard beach attire, which is your swimming suit or your tan-through thing. That's the equivalent of 10,000 international units. A good, hefty dose. Does that mean you should go out and turn pink every day out at the beach? No. You can use smaller amounts with exposing a little bit less skin, 6 to 10%, so that's sort of face, arms, and a little bit of legs, and you can really get enough vitamin D in there. And people have been working it out. So Dr. Hollick is basically, I mean, this is all he does now is vitamin D stuff. I've heard him speak. He's a very dynamic speaker, and I walked away from his talk being more convinced than ever until I went back and went, hey, wait a minute, because some of his data, he really does kind of push things a little bit and emphasize things that may not be quite as useful or true. So, the patient with sun damage, we're kind of coming back to where we started, is they say, what do? I need to get some sunlight. If you already have sun damage, take a pill. Do not try to get more sunlight to get your vitamin D. We have pills, they're cheap, you can buy them at Sam's by the crate, and you will get the vitamin D that you need because some of the horses are still in the barn. It isn't all lost. And we have treatment for what you have. We definitely want to keep it from getting worse. And just remember that so much of what we consider aged skin is really sun-damaged skin. We do have topicals that we can use. Insurance usually doesn't cover these. There are some that are in a moisturizing base, tretinoin, that are really nice. But even the over-the-counter retinol and retinols can do something for you. Some other topical and systemic therapies have been talked about. Does CoQ10 help? Not really. Vitamin C, not really. Vitamin E, not really. Pomegranates, maybe good for other things. I like the taste, but definitely not. Vitamin D may be good for skin cancer, may be good for malignancies, but you can take a pill for that. All kinds of things people will want me to do for their wrinkles, and so many of them come in tan and are just going to make it worse. You've got to develop good habit, or you're really wasting your time and money on a lot of these things that we can do. And you can even go on to laser and laser resurfacing. Current laser resurfacing is nice, less downtime, nice results. Again, not cheap and generally not covered. There is some stuff out there that you have to be careful. If it sounds too good to be true, it probably is. There have been some scandals where people got laboratory-grade Botox, basically a chemical warfare weapon, and have injured people with it. People ask me about these things available at Walmart that are FDA approved to help wrinkles, acne, or whatever, LED lasers. They basically have the same power as this. So if I think that I'm going to help my wrinkles by doing this, then go ahead and get one of these. But they basically do nothing. FDA approved for over-the-counter products and private open purchase devices. You get FDA approval for being safe. You don't have to prove that it's effective. You only have to prove that it's safe. So there's a lot of stuff out there that is FDA approved for over-the-counter stuff that is pretty worthless. And some of it is quite expensive. The topical antioxidant, someday we're going to have some good ones, but nothing you can buy right now. And if anyone ever offers you permanent collagen, they're going to be injecting silicone into you and then you're going to come see me with this awful inflammation and with your face or lips turning rock hard. If you see it on TV, it's probably bogus. If it's online, it's probably bogus too. Never believe the endorsements that are out there. And so I will finish up. We can take maybe a couple of questions. And just a reminder that just because something is old doesn't mean that it's not worth anything. And you know, learn to live with your skin. Thank you. Any questions?